Hey there, it's Rob Arnfield speaking to you. I'll be the director of your junior resident education experience in your upcoming CCTC rotation. We're looking forward to having you on service, and we hope you're looking forward to joining us as well. The ICU rotation for many is a highly anticipated rotation in one way or another. Sometimes anxious, sometimes excited, usually not a neutral feeling coming in. And so this screencast is really designed to try and tackle some of the housekeeping items and maybe do a little bit of demystification of some of the expectations of you prior to arriving on the service, and some sense of what you should expect to accomplish or see during your rotation. You'll also get an in-person orientation on the first day of your rotation that will complement this screencast as well. Our physical plant, the Critical Care Trauma Center, is a large mixed medical surgical ICU, one of the largest of its kind in Canada. Spread across 5 bays, we have 29 beds, typically with one-to-one nursing, and a representative image of one of our bays is seen here. There's an adjacent bay 6 that is a trauma bay for step-down trauma patients who you will not have to look after directly, but will be attached to our physical plant. Now, many of you may identify with this young lady, feeling a bit anxious about the upcoming rotation. So let's take a minute to discuss some expectations and some helpful points of reassurance. One, as an ICU resident, unlike what many feel may happen, the hospital is not set up to place the burden of all critical illness upon the shoulders of a ICU junior resident on their first day of their rotation, nor even on their last day of the rotation. Critical illness is complex and requires a lot of players, 24 hours a day, and though you will have a meaningful, extremely meaningful role in the contribution to critical illness and its management, you will not be alone. In fact, there are always others around with more experience. More doctors, whether it's the form of other junior residents, whether it's the senior residents, the charge nurses, the respiratory therapists. There's always someone around whose job it is, full-time job, is to come to the ICU each day. And these people, whether they're attending physicians or whoever, have devoted themselves to these questions, and they're always around. So just take it easy. You're a key member of the team, but you don't need to own it all yourself. With that in mind, on call, you're often, almost always nowadays, coupled up with a other junior resident, where you can divide the workload and also help each other out throughout the evening. There's always a senior resident who's also on call, anywhere from a PGY4 to a PGY8, who's joining you, who's on home call, who's available to support the events of the evening. The other thing is that many people come into the ICU expecting to see, blood splattering all over the walls constantly, CPR going on in multiple bays at any given time. And the reality is many of our patients, while often quite sick, are chronically critically ill. They've been in the unit for a few days or even longer, a few weeks, and though they have very serious problems, their care trajectory is kind of stable. And so you'll have time to read around these cases. You'll have time to explore diagnoses, to go in depth. And so it's not all resuscitation all the time. There will surely be some exciting days and exciting cases while you're on service, but it's not all mayhem. Many residents wonder what they can do or what qualities they can exhibit to make the most of their ICU experience. Being team-oriented is kind of a no-brainer. That gets you far everywhere in the hospital, but perhaps nowhere more so than an ICU as large as ours with as many team members as ours. If you're team-oriented, it'll get you far. If you struggle in that environment, it'll be picked up. So be a team player. Are you able to learn and receive feedback from all the team members, not just your attending physicians? Our nurses, our pharmacists, our bedside nurses and respiratory therapists, they all live in the ICU, and they have things to teach you as well. So seek out their expertise and receive it with grace if they have something to maybe give you some constructive criticism or feedback. Reliability and trustworthiness are the two qualities I think I comment on the most when I refer to someone's character in an evaluation, and I'm hopeful that you can bring those to the table during your rotation. That certainly will distinguish you as a great resident. Work ethic isn't far behind either, and certainly hardworking residents get the most out of the rotations. They learn the most, they get the most procedural opportunities, and that work is very much appreciated by the team. Having insight into your limitations will protect you and protect your patients from getting into too much trouble. There's a very exciting number and breadth of procedures and diseases in the ICU to take part in. And indeed, we wish to teach you how to expand your limits. But if you're on your own, call for a little help or acknowledge that you're over your head, and that'll be seen as a sign of maturity and strength rather than weakness. And the inverse is true. Those who fail to know their limits are often flagged as slightly dangerous, and you'll get into more trouble that way. Other helpful qualities that will help you survive your ICU rotation and perhaps digest it a little bit easier. Think of the big picture. There's a lot of details, and there's a lot of noise amidst those details. And if you can think about the big picture, and I'll show you an image in a moment that will help you, you'll navigate your ICU experience a little bit easier. Synthesizing complex situations into more simple situations. Patients come in with a vast array of problems, lots of organs that might be failing. What's the underlying reason for it? And can you unify a diagnosis amidst all of the other problems that are going on? And as you're doing that, you're going to be taking a lot of tests and a lot of blood work and a lot of information, multiple histories from multiple services. Can you figure out where the important pieces are in that noise, the signal in the noise? That's one of the key qualities that will allow you to do well by your patients and make this otherwise overwhelming environment much more digestible. Comfort with uncertainty. We have a lot of uncertainty in the ICU. Despite all our tests, we often can't figure out always what's wrong with people, or there's a little bit of shade of gray here or there, and being able to kind of roll with those punches a little bit will make your experience a little bit easier. We deal with a lot of death in the ICU, and a lot of that death, most of the time, is expected and or arranged through the withdrawal of life support. And understanding that death is a natural conclusion to life in many of these instances rather than a failing of the medical system will help you deal with your own grieving and your own sense of purposefulness in an environment where obviously we come to work with the hope to save life rather than to witness death. Not required on day one. Things that you might think, oh my goodness, I'm nervous about my ICU rotation. I can't believe that I don't even know how to manage a difficult airway. Well, that's not really expected. It's a bonus if you come in with those skills, but we don't expect you to come in with those skills. Nor do we expect you to have mastery of the ICU pharmacotherapy, experience with central venous access, exhaustive knowledge of ventilators, or a complete understanding of vasoactive drugs. These are things that we hope that you will seek out maybe prior to your rotation. Maybe you'll be interested enough to read, and you'll certainly be assigned or given the ICU boot camp videos to watch ahead of time. But you're not expected to come in able to do those things right away. So with that in mind, you will get a link, and that you may be watching this as part of the ICU Bootcamp series that will cover some of the broad brushstrokes of kind of ICU 101 type stuff. Up to Date is an extraordinary resource, as we all know, and the ICU sections are no different. So if you Google, or rather search for ventilators or vasoactive drugs or anything related to critical care, you'll find some great succinct articles that will really get you started and give you a sense of what our specialty is all about. There's a blue book called the ICU book, which has been floating around for a couple decades and always kept up to date, and is an easy read, very cool physiology-based book, and I'm sure you can find it readily. We have an intranet site that you can access through the LHSC page, which has a lot of cool information. And of course, there's never-ending stream of podcasts and social media stuff out there, including the Intensive Care Network and mcrit.org have a ton of stuff. Our own managed westernsono.ca covers a lot of the ultrasound related topics that you'll encounter over your rotation as well. So this is the image I was referring to, designed by my friend Ruben Strayer, which captures in a ironic cardiac myocyte distribution the trajectory of ICU illness. And it sort of speaks for itself, and you can take a moment to read it over. But ultimately, we go through, classically, with all patients, a period of identifying critical illness, resuscitating them, stabilizing them, protecting them, and we'll come back to that, how we protect people from the costs of ICU care, and eventually the de-escalation or de-ICUing, de-resuscitation. A lot of emphasis on that these days, trying to get people out of this frame as soon as possible so that we can transition them back towards the quality of life that they would want. So this picture is also on the wall in the team room, and you can have a chance to look at it as well. The team is large. I've made mention of this already. You are a very important player in the team, but there is a large number of people, a large number of faces, but you'll make some great contacts both in the medical and non-medical realm during your rotation. So what does a day look like in the ICU? There's lots of moving pieces, and for you it's a busy day. Typically every morning there's going to be a teaching session or something educational at 7:30 in the morning that you're to attend, followed by morning rounds. And then the day's work. You're going to go out and see some patients, you're going to write some notes, there'll be a few procedures to be done that you can do or help out with. There's family meetings, which I think are among the most meaningful part of the ICU, where you discuss care trajectory and patient values and recognize that we can do anything in the ICU, but should we is always the question. And that's where that takes place. So that's the daily workflow. And after that, you're going to, ideally, we might have a bit of time to sneak some teaching in the afternoon on a whiteboard with one of the fellows or one of the consultants. And then by the end of the day, you're going to do it all over again and do rounds around the bedside. We'll walk around. And the point of that is to sign out to the on-call team. Now, there's teaching rounds in the morning, which you'll be given access to via an electronic calendar, and we try to bring in a slew of different bodies to tell you about different topics that are germane to ICU and to resuscitative medicine in general. Now, the morning rounds are important to discuss because ideally you can assign your patients to yourself or to your team members before morning rounds start. That way, when you're reviewing 20 plus patients, you know which patients are yours, and you can prioritize what your plan for the day is when your patient is reviewed by the overnight team. Now, the rounds themselves are sort of a structured fashion when they're done in the team room, which is typical. We sit down and discuss the patient as the on-call resident overnight, and that will be you at various points. You'll speak about each patient with a brief thumbnail about their admission diagnosis and really what happened overnight and what the issues you expect to be for the day. So not a lot different than any other rounds in any other service, though because we're talking about a lot of different organs, you need to be systematic and need to prioritize what you really need to talk about. After you do your spiel, the respiratory therapist will comment on the respiratory needs of the patient. Then the bedside nurse, who will come in with the patient's chart, will speak, and then there's kind of a wrap up with the consultant and the rest of us as we kind of map out the plan for the day. It's just kind of been systematized again to try and keep things on track and make things efficient, which everyone appreciates. So this is a view of our lovely board that we have in the team room, where you'll, again, ahead of time, your name will be assigned to a patient room based around perhaps patients you've been following primarily, patients with diseases that you're particularly interested in, or simply just a matter of getting the work done. So on day-to-day, your life at the bedside, you're going to examine your patient. Most of our patients are unable to complain. They're sedated or receiving some degree of analgesia, and they may have an ventricular tube which prohibits their ability to speak. So you must examine them. You feel their belly, look for bed sores, that kind of stuff. Prioritize your patients. Follow up on test results. So test results stream in through the day, and in afternoon rounds, when you say, well, they had a CAT scan today, look up the CAT scan results immediately prior to afternoon rounds, so we're not waiting on test results. Call the radiologist, call the cardiologist, get the results of the tests that have been done, even if they're not reported. Certain orders and certainly some care plans, if you're unclear, discuss them with the seniors or the consultant. Dictations, now we're still in an awkward phase in our hospital, informatics with Hugo and a number of other things. Ultimately, a dictated note is a more meaningful form of communication than anything that's ever been handwritten. And if you are transferring a patient out of the unit, they need to have a in-hospital transfer note done. If they're going home, which is sometimes the case for very, very stable patients, discharge summary or a death summary, as the case may be, depending on what their destination is after discharge. And we may eventually move to the advanced clinical note, where you can type your daily progress note, and that may or may not be in place by the time you watch this. CCTC Grand Round. So every Friday is a morning presentation, a reprieve from the teaching that is done for you, and instead you become the teacher. One of you each week will become the teacher of a topic, ideally a topic that intertwines with your specialty and how that specialty intersects with critical illness. There's a few obvious answers for every specialty, but try and be innovative, try and keep it snappy and interesting. Try not to read your slides. Try to make it a good talk. This is designed to not only allow you to master some content, but also to practice the important skill of delivering a lecture or a talk. And once a month, there will be citywide rounds that will be done on a citywide basis, and they're provided typically by one of the consultants or a visiting professor, and you'll be made aware of that. And those will replace the Friday morning CCTC rounds. So what does an on-call look like? Well, every call is a little bit different, but ultimately you're going to ally yourself with your buddy, your other junior resident, and the charge nurse. The charge nurse will change shift, of course, at around 7 or 7:30. So make sure you introduce yourself to the evening charge nurse, let them know who you are if you haven't met them, and you'll work very closely with them. They are the gatekeepers of the resources of the unit. They're the ones who understand if we can admit patients, where they go, everything else. So before you even think about admitting a patient, you can always talk to the charge nurse, and that will become very clear as you work through the month. You'll divide probably the unit in two with your co-resident, and that way the nursing staff will call just one of you for any given problem, and that splits up the work and splits up the phone calls, which is nice. And there's a lot of anxiety appropriately about managing airways if you're not a expert or even comfortable with airways. There are respiratory therapists we have frequently intubate and are quite capable, especially with straightforward airways. If the airway appears to be difficult, or is known to be difficult, and time is of the essence, then there's always an anesthesiologist in-house, and they kindly will help you out in emergency situations as well. Again, if desperate for access and not comfortable with central venous access yourself, anesthesia may be able to help, but ultimately, if you have any degree of time, the senior resident or the consultant can provide you with support there. New admissions on call should be generally reviewed with your senior, and ideally at time of arrival, so the senior, especially because they do home call, can triage whether they need to come in right away, and do not wait until after a couple hours until you realize the patient's really super sick to come in. And if you're seeing patients upstairs on CCOT or in the emergency department, you should really talk with a senior before you admit to the unit, unless the patient obviously requires admission, for instance, if they're intubated, in which case you may see them and admit them to the unit and call the senior as that's happening. In general, escalation of any kind should go to the senior, and if the senior for some reason is either occupied or unable to be reached, then obviously just call us, the consultant team. We're here to back you up just as much as anyone else. Now that's the planned workflow. There's a lot of unplanned workflow in an ICU environment. Those things include code blue on the ward, pre-arrests, which are typically called and usually get a response from you and the CCOT nurse. CCOT is the critical care outreach team, as I'm sure many of you know, and is a respiratory therapist and a nurse on with kind of a mobile service they provide. CCOT collaboration, so there may be patients smoldering upstairs in the ward, and the nurse may want you to come up and have a peek because they're worried about somebody. And again, those are the most interesting calls, the pre-arrest and the CCOT calls, I think, as a junior resident, because realistically, unless you're planning on working in an ICU, recognizing and managing critical illness outside of the ICU is really the skill you're hoping to be able to acquire from this rotation. Other services may call you to help out with opinions, rarely with procedures, and in general our party line is that we aren't really the central line team as the ICU team, so if you get calls like that, just run them through your senior in case you get a call asking you or demanding that you as the ICU junior have to do central lines all through the hospital, which certainly is not the case. The pager. During the day, there's a code pager which we wear, and you'll wear it. One of you will always wear it at any given time of day. And a code blue generates a cardiac arrest team, and the response includes us and the CCTC and the CCU resident, who typically is in charge of running the code in terms of orchestrating the work. There's always a respiratory therapist and nursing staff there as well. Now, code blues are high anxiety situations. Ultimately, our role is to help with the airway. And again, an RT is there. If you're inexperienced with the airway, often the RTs can help. and to help out with venous access if it's required. Pre-arrests only get CCOT and U, so again, you won't get that huge response that you get from a code blue. It can sometimes feel a little bit lonely, but you can just make shout outs to whoever you need to, whichever services you need as situations dictate. Usually that will always include the most responsible physician's team. So if it's a medicine patient, make sure the medicine senior's there. If it's a surgery patient, it's a surgery senior, etc. If there's consults or admissions that need to happen during the day, usually that'll get sent to we'll ask a resident who's not on call to do those, so that you're given a break if you're on call that night of having to do that during the daytime. This is one of 2 procedure carts that you'll make use of during your rotation, which you'll make a good use of, and I know many of you are excited about learning to do some of the invasive procedures we do here in the unit, so this will be your friend. Features most of the things you'll need, and we'll go over it on the day of your arrival to the rotation. But some of the common procedures that you're going to do, central venous access is extremely common, often an ultrasound guided IJ, so we'll be sure to look at the ultrasound guidance screencast that's part of this series. Arterial access, same thing, ultrasound guidance often. Endotracheal intubation, a lot of airways, a lot of non-invasive ventilation as well, which which is good for patients but bad for endotracheal intubation experience. And but regarding intubation, you get experience both with glide scope and with direct laryngoscopy, we hope, and you'll have a dedicated intubation workshop at some point during your rotation. Chest drainage, whether it's a full bore quote-unquote surgical chest tube or a Cook catheter, a percutaneous tube. There's always pleural effusions and pneumothoraces to be drained in an ICU environment. Similarly, there's always acidic fluid that needs to be removed as well. And the odd time, probably a few times a month, we have to do LPs for undifferentiated neurologic disorders. Now, regarding procedures, it's it's obviously they're fun to do, but as we know, sterile precautions suggest that you have to go through a few hoops before you get to stick needles in any particular place, and we have universal sterile precautions for all our procedures here. So hand wash, gown, mask, cap, gloves, skin prep, large drape area for all lines, including arterial lines. It's different than the operating room because our arterial lines stay in for a long time. Now, you need to document procedures. If you've done it and it's successful, great, you'll proudly document you did it and it was successful. If you didn't succeed, lamentably, you'll have to still document and say, yeah, you weren't successful. There's a special sheet for each procedure that helps you with the documentation process. It's, and we want to document line insertion, line attempts to try and track infections that may occur, and that's not to point fingers, it's just to understand what are the factors that contribute to line-related infections. And the nurses will remind you to fill out these forms, and they're not trying to nag you, they're just trying to ensure that you meet your obligations as a resident, so they're helping you out. Now, ultrasound is a huge part of our culture here at Victoria Hospital and the other hospital as well, but particularly here at Vic. And you'll see lots of ultrasound use, which will hopefully be an important and nice part of your rotation. The machines will be used to help guide procedures. Right now we have 2 machines, we'll have a third on the way soon. This taller machine is ideal for vascular access. It has a single vascular access probe on it, and because it's not used for any other purpose, is ideal when doing arterial lines or central lines. This guy here can do vascular access as well, but it also has the ability to do cardiac and abdominal imaging. Now, it's not as sexy as doing procedures, but things like washing your hands and washing in and washing out with the alcohol rinse is perhaps one of the best things you can do on your rotation. So let's get with that program, okay? Other things that we talked about, protecting our patients from the cost of being critically ill. And here's a list of things that we will, each area will be addressed on your rotation. We talked about hand washing, the head of the bed being elevated to prevent ventilator-associated pneumonia, DVT prophylaxis, de-lining patients as early as possible to avoid clots or infections, early nutrition, paying attention to skin care, lung protective strategies, low glycemic indices, and keeping sugars from going way out of control. These are all little things that will add up to making sure someone's ICU trajectory doesn't have unexpected inflection points on it. So be sure to sign up for your Friday grand rounds soon after you get on service. There's a sign-up sheet just outside the conference room. There's occasionally simulation sessions as well at the north end that you're welcome to attend and should sign up for as you're invited to do so. Rebecca Rondinelli is the secretary for the junior resident experience, and you'll have dealt with her, I expect, already by this point, but changes to the call schedule or other matters, administrative matters related to your rotation should all go through her. Make sure you dispose. We have a lot of worksheets designed capturing the patient lists. Those all have to go in confidential baskets. And there's some codes there at the bottom for the resident workroom and the nurse's lounge that you can commit to memory or pull up as you need. So you may just take a moment to write those down now or put them in your smartphone as we transition to the next slide. You've got a couple of rooms. Each of you has a room on call. They're kind of nice rooms with like suite showers in them, and bed and a desk, and they're not bad. But keep them clean. Don't bring vials of meds in there, needles. We've seen everything. Just try and keep it clean and get rid of your sharps. You'll get an evaluation, of course, at the end of the rotation. I'd like to ideally sit down with you to discuss your rotation. We learn from you, and hopefully you can get some stuff from us. I collect information about your rotation from everybody, so a big email goes out to the entire staff, nursing, allied health, everybody. So it's kind of a crowdsourced evaluation, and we'll try and meet, as I mentioned. If there's issues or just concerns, we may have an interim evaluation halfway through your rotation. And if you would like an interim evaluation to see how things are going, you can request one as well, and you can contact Rebecca and she can schedule something with me. Have a great rotation.